Thank you, and hello everyone. I'm Rebecca Ivers, Professor of Public Health, and I'm Head of the School of Population Health at UNSW Sydney. Before we start, as is customary in Australia, I'd like to acknowledge the traditional owners of the land UNSW is built on, the Bidjigal people, and pay my respect to elders past and present and any First Nations people here with us today, acknowledging them as the first scientists, first healers and ongoing custodians of Australia. Today, I'm really excited because today we have a live webinar from Delhi in India. It's the first joint public health seminar between UNSW and the National Centres for Disease Control in Delhi in India. This seminar series has been established as part of a partnership aimed to extend and strengthen scientific exchange and cooperation between Australia and India. Many thanks to Dr. Atul Goel, Director General of Health Services, for facilitating this significant opportunity, and at our end, Amit Dasgupta for working tirelessly to make it happen. I've worked in India myself with Indian public health researchers for many years, and I'm delighted to be able to further promote opportunities for information gain and collaboration in public health research between our two mighty countries. And of course, UNSW has had a long history of engagement with India. Students from India have been studying at UNSW since the early days of the Colombo Plan, dating back to the 1950s, and many of our leading academics have joined us from India or have Indian heritage. In addition to collaborations in health, which are significant, UNSW academics are also collaborating with the Indian government and industry partners in areas such as transport, photovoltaics, optometry, water and waste management. And of course, we have a long and proud history of research and teaching in public health, including infectious disease management and control. So I'm sure this seminar today will be of great interest to many. Before we start, I would like to invite Dr. Meera Dhuria, who's co-director of the National Centres of Disease Control in Delhi, to make a few introductory remarks. Over to you, Meera.
Thank you, Professor Ivers. So, indeed, welcome from NCDC, Delhi. I would just like to give an overview of the National Centre for Disease Control, which is a national public health institution that supports the Ministry of Health and Family Welfare, Government of India, state health departments to channel the epidemiological insights and science in public health, policies, procedures. So it was founded as the Malaria Control Bureau almost more than 100 years ago. But now our mandate has been expanded from communicable diseases to also non-communicable diseases with environmental health, climate change, non-communicable diseases also being handled by NCDC. Our core mandate is disease surveillance and response. We also do provide some referral diagnostic services, capacity building in public health and field epidemiology, operational research for public health programs, and also the program evaluations, along with implementation and technical support to national health programs. Few of the national health programs, the flagship programs of Government of India, for which National Centre for Disease Control is the nodal agency, include the Integrated Disease Surveillance Program, the Central Surveillance Unit from where Dr. Himanshu comes. And then we have the National Program for Containment of Antimicrobial Resistance, the National Program for Climate Change and Human Health, the National Rabies Control Program, and National Program for Prevention and Control of Zoonotic Diseases, also known as the National One Health Program. These are few programs to name, and also NCDC has a pan-India expansion plan through our flagship program of the Honorable Prime Minister, the Prime Minister's Ayushman Bharat Infrastructure Mission, through which we will have NCDC branches all over the country with some state branches and 5 regional NCDCs. So with this, I hand it over back to Rebecca. Thank you.
Thank you very much, Dr. Dhuria. It's fantastic to have the opportunity to hear from you and Dr. Himanshu today and hear about the extensive work of the CDC. I'd like now to introduce our speaker and our expert discussant. Today we're honoured to hear from 2 expert speakers, Dr. Himanshu Town from the NCDC, and an expert discussant, Dr. Sarah Britton, who's the Director of One Health at our Australian Government Interim Centres for Disease Control. Dr. Himanshu is a medical graduate from the Maulana Azad Medical College in New Delhi and a postgraduate from the Lady Hardinge Medical College in New Delhi. He's pursued advanced fellowships at the US CDC in Atlanta and at Maulana Azad Medical College. He's a public health specialist with more than 20 years of experience in diverse capacities and situations, and public health emergency management is his area of special interest. He has authored many papers published in peer-reviewed journals and is a member of many professional bodies. As in his present role as a joint director of the National Centre for Disease Control and head of the Integrated Disease Surveillance Program of the Ministry of Health and Family Welfare, Dr. Chauhan has led the transition of the Integrated Disease Surveillance Program into an electronic real-time platform, which we will hear about today. Following that, we'll hear from Dr. Sarah Britton. Sarah is an experienced executive leader with 30 years of One Health and biosecurity experience across government, private and not-for-profit sectors. She's the director of One Health in the interim Australian CDC, the principal consultant of One Biosecurity Solutions and a non-executive director for Australian Eggs. She was also the New South Wales Chief Veterinary Officer leading multiple emergency responses such as Japanese encephalitis and owned 2 veterinary practices in city and regional locations. She's passionate about One Health and improving health, human, animal and ecosystem health, and is going to be a wonderful respondent to the discussion today. So thank you everyone for joining us. We will try to get to questions, so please add any questions that you may have in the Q&A and we'll answer them at the end of the session. I will now pass over to you, Himanshu. Thank you very much.
Thank you very much, Professor Ivers, for that kind introduction. And at the outset, greetings to all the participants who have connected virtually with us in the first of this webinar series that we've planned. Also, I'm thankful to DGHS and Director NCDC for cementing this partnership between UNSW and NCDC India. And a special thanks to Professor Ivers and a team at UNSW for making this happen. So the topic that we have for the inaugural webinar in this series is a brief talk about the surveillance and response system that we have in India to outbreak-prone communicable diseases. So the program is Integrated Disease Surveillance Program, and we recently commemorated 20 years of its existence in November 2024. So it's an apt opportunity to reflect upon the 20-year journey of IDSP. The Integrated Disease Surveillance Program, its background, if we just talk about quickly, India, given its geography, climate, population, and other variables, the entire Indian subcontinent is no stranger to outbreaks and epidemics. In fact, history is replete with major epidemics ranging from cholera to plague, influenza, smallpox in the early 20th century. India has always responded well to epidemics, especially when they assume the proportions of a disaster. However, a systemic approach to outbreak detection was conspicuous by its absence, and that was realized by the policymakers, and it was further driven by the large outbreaks that we witnessed in the 1990s, early 2000s. Some of them were like the plague outbreak in Surat, the dengue outbreak in Delhi, SARS-CoV, the SARS outbreak that India was spared, thankfully, but meningococcal meningitis was another major one. So there was a systemic surveillance and response approach to it, and the National Surveillance Program for Communicable Diseases was initiated at National Center for Disease Control. It soon grew and matured into a more systemic approach and was labeled as the Integrated Disease Surveillance Program in November 2004. It was just in time because in 2006, we saw the first avian influenza outbreak in Maharashtra. So the system which had just been created was put to test in 2006. And the pictures on the right, they depict the scare that was associated, the response that was launched into the first avian influenza outbreak that we had. Talking about the program, what are the objectives? The main objective is to detect early warning signals of impending outbreaks and to initiate timely and effective public health actions against them. This is to be achieved through the creation of a trained cadre of responders at all levels, the national, state, and the district levels. These are named as the rapid response teams. Reducing the mortality and morbidity due to communicable disease outbreaks is the ultimate objective of having this system in place. And the system is present across the country through the district surveillance units, one in each district, There is a network of district public health laboratories and rapid response teams stationed in every district. And I'll talk more about how do we collect the data, how do we do the surveillance in the subsequent slides. So just to take you quickly through this 20-year journey, the major milestones. So the early years of IDSP, much of the time during the initial years was spent on creating a reporting and response system. So how do we get the data regularly, which can be used as an indicator for early warning signals? So the weekly reporting of disease alerts and outbreaks was initiated in the year 2007. Followed by realization that a lab network has to be established parallel to this data collection system, and a call center for IDSP where disease outbreaks can be reported was also initiated in the initial years. And soon the system was put to test when we had the first novel H1N1 influenza case in 2009, and it proved that yes, there are some gaps which need to be addressed, but the system is very much required and needs to be strengthened a lot. As the system continued to evolve, we saw in 2010 major restructuring with mainly the support from the World Bank, which was used to initiate the program transitioning into domestic funding. A referral lab network was also launched. The migration of the reporting system. So one can well imagine at that time, email was the only technology which was available for reporting data timely. So email-based data was transferred to a portal system, wherein a dedicated portal to report the diseases and the conditions was established. The system continued to evolve. The data entry efforts were taken to the block level, from the district to the block level. And the portal also saw some auto-generated reports which helped the rapid response teams and the district surveillance units to take timely action. And soon in 2012, there was a major outbreak of acute encephalitis syndrome in Bihar, Muzaffarpur, which faced recurrent outbreaks almost every few years. This outbreak left 120 children dead, and the Bihar unit, state surveillance unit of IDSP, played a major role in this outbreak response as well. The further consolidation of the program took over the next few years with mainly a public health emergency operations center being established at NCDC to respond to major emergencies in a more systemic way. The 2014 year saw IDSP commemorating its 10 years of existence. And then in 2015, a joint monitoring mission of experts, global experts, undertook a detailed review of the functioning of the program and came out with major recommendations that saw the subsequent transition. So this was the first step towards transition from 2015 to 2018. Essentially, what was recommended was that there needs to be a major overhaul of the reporting system. So it cannot work on a weekly basis, aggregate data. So it has to be more real time and has to be a case-based surveillance system to be put in. So efforts were initiated towards that. And in 2021, a new beginning in the history of the program, which is essentially migration from a weekly reporting system, paper-based reporting system, to an electronic system was done. And this was the pan-India launch of the Integrated Health Information Platform in April 2021. However, our efforts were met by the second wave of COVID-19, which immediately followed this launch, and therefore the expansion of the program to all the states took some time. And once we were out of that COVID second wave, the conditions posed by it, the further expansion continued along with the response to COVID-19, which continued till 2023 as the major public health emergency that we were dealing with. And the last year saw some add-ons to further strengthen the reporting system, which was through launch of a community reporting tool. So once the community becomes a partner in the surveillance system, the eyes and ears of the system are enhanced many-fold on the ground level. So that was the launch of community reporting tool by the Honorable Minister. We also did a kind of a war game where we tested our preparedness and response capacities, which was Vishanu Yuddha Abhyas, which literally translates into a viral war game. So all the stakeholders came together and tested our preparedness and response plans. November 2023, IDSP observed its 20 years of existence, and we commemorated and celebrated it with all the stakeholders. So that was a brief history. Quickly talking about how it is structurally organized. We see the central surveillance unit located at the National Center for Disease Control. There are state surveillance units in all the states, India being a federal system, as is well recognized. So the states, the health, public health is a state subject. So the states have the final say in the matters of public health and especially emergencies and outbreaks. So there are 36 state surveillance units, and all the districts have a dedicated district surveillance unit, which is supported partly by the central government and partly the states also bear the cost of running these units. A glimpse of what is the mandate of IDSP presently. So there's the health condition and diseases. If you look at that, there's more than 50 conditions that we keep an eye on. Not all of them are present at all the times, but there are certain conditions which have to be always kept under close surveillance, close monitoring, while some of them are on an ad hoc basis. So an mpox case which may be imported may have to be followed only for that period of time. Yellow fever, we don't have it, but our vigil is always up at the points of entry. And so is for MERS coronavirus and Ebola, which India doesn't see and report. But the other conditions are very much endemic and a close watch is maintained over them. The Integrated Health Information Platform, as was being referred to by the Director General of Health Services in his opening remark, it is an electronic health information system. So this should be very clear to the participants that the program is Integrated Disease Surveillance Program, but the way the program works, the reporting platform is the Integrated Health Information Platform. So this has many advantages. I'll just go through those in a little while in subsequent slides, just to give you a demo rather than talk about these advantages as to how do they actually look. The key difference between the earlier way we worked as integrated disease surveillance program and the way we function on integrated health information platform is essentially this change that from aggregate data, we are now capturing the case-based data. So it's disaggregated surveillance. Earlier, there was no linkages in the three data collection arms. Now they are all linked. Being electronic data, they can all be linked to each other. The paper-based data collection system has been replaced with an electronic collection and transmission system. And the weekly reporting being too late as one of the recommendations of the joint monitoring mission has to be replaced with a real time. So now we are in a daily or a real time surveillance system. And this also saw us the mandate being expanded from 18 conditions that earlier was our mandate to now 50 plus. The slide says 40 plus. I just gave you a glimpse of about 50 conditions being listed. And the data was not geocoded. So all the attributes of an electronic surveillance system, they come along with this migration now. So this is the landing page, how it looks like. I'll just take a couple of minutes to just take you through the salient features, give you a demo of the salient features of how this program works. You can see there's a lot of programs and schemes listed over this. The idea is that over a period of time, all these programs, their surveillance data would be placed on the integrated health information platform, which is essentially a technology solution on which all the data could be placed. And then the ease of data sharing between different programs, and therefore the effort of collecting data and the error of duplication of data could be minimized. So with that idea, some of the programs have already been migrated. As you can see, the ones which are listed in blue, they are already using IHIP for their surveillance data collection and analysis, while the others are in the process of considering the migration. So IDSP is one such program which was a pioneer through which this platform was also tested whether it is stable enough, whether it would be able to handle all the voluminous data and do justice with the output. So this is how it looks like. Every user has been given a unique set of credentials, username and password. Depending on the role that particular user has, he or she is taken to that particular place where they can play their intended role. So whether it is the health secretary or the health minister monitoring the data, obviously they would not be doing data entry. They would not be collecting data. So they only need to see and monitor. So that's where they would be landing up upon logging in. While a PHC medical officer or a health worker in the community, they would actually have to collect and enter data. So they would land up at that page where data entry can be done. So just some key features, the point that I was mentioning about that you land up based on your role at the right place. So We have currently, the S form stands for syndromic surveillance. So this comes from the community, and there's almost 180,000 users of this S form. So that means there are community workers who collect data and feed into the portal. There's a very simple app. They can also do a web login. Again, they feed in their credentials and do the basic reporting. The essence of this reporting is that early warning signals are picked up from the community itself before they evolve into major outbreaks and they reach the health facilities. So this is captured, it is fed into the system, and it's immediately visible once the data is entered. It's logged on to the servers, central servers, and everybody connected to the system can visualize that data, can make use of that data. Similarly, we have health facilities which use the P form. P stands for presumptive diagnosis. So the presumptive diagnosis is entered through a P form. There's almost 46,000 plus users who are using the P form and very basic attributes, because this is essentially an incident capturing system. So we want to just capture the presumptive diagnosis, even if a lab diagnosis is not available at that moment, just to alert the system. The health facility medical officers make use of this P form and they enter their provisional diagnosis. As you can see, section 2, clinical details, provisional diagnosis, and they select one provisional diagnosis and enter it. It's immediately visible. They are also referred to lab where a more confirmed diagnosis is arrived at and the lab confirmed conditions are then available to visualize. In addition, we also use event alert form. So this can be generated by any of the users, even community, as I was mentioning, that community is now partner in surveillance. So the community witnesses, any member of the community witnesses, any unusual happening in and around the neighborhood, they can also make use of this and report it. I'll talk about the media scanning cell in a little while. So these are the input arms of how the data is collected and fed into the system. How does that data translate into and what does it look like once it is processed? So we use lots of dashboards. This is a glimpse of a snapshot of the reporting status dashboard, which is available, very often used. The data is updated just to reflect the last week's performance. As you can see, this a million plus records from the syndromic surveillance that's coming into it, almost a million cases from the health facilities, and 500,000, more than 500,000 lab confirmed cases being reported into it. And what is being reported can also be seen. So from the lab side, we are seeing enteric fever, measles, dengue, strep typhus being the major conditions in the last 1 week. While on the presumptive and the syndromic surveillance, we see fever and related conditions, cough. This is influenza season as well, so fever, ILI-like illness. They are the ones which are predominantly seen now. The reporting status dashboard is also used to monitor how the states are performing in terms of, because unless they make use of it, they do regular reporting from their health facilities, we would not be able to have good quality data to be able to take decisions in a timely manner. So this is continuously monitored. We see that there's a state which is in red, but most of the country looks like it's performing at a satisfactory level. So almost 80% is the current reporting. That means 80% of these facilities, these reporting units, are reporting on a daily basis. We also see their performance in terms of assigning them scores. So these are our monitoring tools. We don't need to get into depths of this, but just to give you an idea that state and district level performance is continuously monitored and feedback is provided to the state and district surveillance units from the center. One important tool that we use is, this is important for decision making, is the use of heat maps and marker maps. So the heat maps, this left side, the heat map is a typhoid heat map from the state of Tamil Nadu. So we see that there are certain pockets where there's more intense transmission going on, and this is a month's data that has been captured into it. So this helps identification of those hotspots where a more focused intervention needs to be undertaken now. And this can be zoomed down and actually up to the street level, or at least up to the facility level, it can be seen which are the worst affected areas. Similarly, for conditions like on the right, we have acute encephalitis syndrome, where each and every case matters as to where it is coming from. So this is from the northeastern state of Assam, where we see the acute encephalitis syndrome cases being reported. Each place marker on that map shows a case of acute encephalitis syndrome being reported. So this is an important tool when we talk about. I think we just had. My apologies for yeah. So we were at this point. In addition, we also have because this is an electronic platform. So the special surveillance based on what we want to achieve at that moment. Sometimes there's a temporary need of mounting a special surveillance for a condition like COVID-19 was for that brief period, 2 to 2.5 years. That was the priority. So a special surveillance module was created for COVID-19. And we monitored every aspect of COVID-19 on this, which ranges from the cases to the deaths to tests which have been conducted, case fatality rates, and every aspect of COVID-19 response. Similarly, special surveillance module exists for influenza. This is the influenza surveillance dashboard, which gives a glimpse of the data over the last 1 month. So we see that there's an increasing trend in the recent weeks, and that's the influenza season that we are witnessing in the northern part of the country. And mainly it's influenza B that is currently the predominant circulating variant. So these special surveillance modules are made use of on a need basis. In addition, we are also using it for special events like right now there's a mass gathering in Prayagraj. So the Kumbh Mela gathering, we have instituted a special surveillance module for that, just to monitor if there's any outbreak prone condition developing in that mass gathering. So these special surveillance modules can be mounted on a need basis when required. So this system essentially depends on a lot of support from various corners. So these are the pillars of strength that IDSP has. The leadership at MOH and FW, which goes from the political leadership to the administrative and the technical leadership in the form of DGHS and Director NCDC. NCDC and its various divisions, they are partners in this surveillance. NCDC's core mandate is surveillance and response to diseases. So all the divisions of NCDC, they have their mandate which acts as a pillar of strength for IDSP to function. In addition, the Indian Council of Medical Research and its lab network that they have across the country, which is an advanced lab network, they help during the times of outbreaks where samples can be sent, and routine surveillance also, which comes from the labs. This is an important partner that we have. Besides the human health side, we also have animal husbandry department. Many of the outbreaks, they initiate in the animal sector and are passed on to the human health side. So having a close partnership with Animal Husbandry Department, the Food Safety and Standards Authority of India, which is monitoring the foodborne outbreaks together with IDSP, the National Institute of Disaster Management, because public health emergencies and disasters essentially are two sides of the same coin. So working closely with them, and needless to say, the state and district surveillance units are the main pillars upon which this entire system rests. So a strong district surveillance unit leads to a better performance, leads to earlier detection of outbreaks, the early warning signals, and a better response to them. The labs that we have in the form of district public health laboratories and state referral laboratories, they are the key pillars upon which a confirmed diagnosis from an outbreak rests. I'll also like to talk briefly about the media scanning and verification cell, which is essentially an event-based surveillance. So while the indicator-based surveillance depends on what quality reporting happens from these reporting units, but the media scanning cell is one which functions continuously in the background. So essentially, it's an AI tool which has been designed to be able to capture round the clock the media reports related to outbreak-prone diseases. These are passed through a series of steps and ultimately converted to an event alert. So once an event has been picked up in the media and it is found to be actionable, it is passed on in the form of an event alert to the concerned district surveillance unit for verification. And if it is indeed true, then subsequent action is to be initiated on that. The Public Health Emergency Operations Center at NCDC is the nerve center for major responses. Whenever there's a major emergency that the country faces, the Public Health Emergency Operations Center is activated, just to have a more focused response to that particular emergency. So these are the recent activations of the Public Health Emergency Operations Center that we've seen. The last activation was in response to the human metapneumovirus scare that reports started trickling in, that there's an increased upsurge in China and other countries of human metapneumovirus cases. So a continuous and close vigil was kept on this as well. The PHEOC is it's one of the most frequented places by visitors who visit NCDC as well. So this is a glimpse of the activated PHEOC. This was during the time of Chandipura virus, which led to acute encephalitis syndrome in the state of Gujarat last year. And that was a full-scale activation that we saw. This is the photographs indicate the various visitors from abroad as well as within the country who have visited and saw the action at PHEOC. And lastly, the pillars of strength, it would be incomplete if we do not mention the partners who have worked with us, who support us in doing what we do. Quickly taking you through, as the time I see it is hitting that 30-35 minute mark that I was originally allocated. So with this system in place, what we've been able to achieve, the migration of this system from a weekly aggregate system to a more responsive electronic real-time system, that's created a data-driven decision system which helps everybody, right from the policymakers, the decision makers, to the rapid response teams who are there out in the field. The year 2024 saw over 55 million syndromic cases, 46 million presumptive cases, and 33 million lab tests being reported on this network through IDSP. This highlighted a data-driven approach to outbreak detection and response. Nearly 3,000 outbreaks were detected through the system in the last year. Main outbreaks that were detected and responded to were acute diarrheal disease, food poisoning, measles, and dengue. The media scanning and verification cell generated a total of almost 2,400 alerts during the last year, and many of them were early warning signals of impending outbreaks. Actions were taken and they were contained. This lab network that I was talking about is like the backbone. So without a lab confirmation, outbreaks remain in the domain of uncertainty. Once we have a lab confirmed diagnosis, our actions can be more concerted. We can take more specific actions to contain them. So there's 439 district public health laboratories under the program, of which almost 85% are functioning optimally. The state lab referral network is also a more advanced lab network where the districts are not covered under the lab network. The medical college labs have been strengthened to provide those services. We responded. IDSP has been at the core of every major outbreak that's happened in the country by virtue of its mandate that's been assigned to it. More recently, we are handling avian influenza outbreaks, which in the poultry. So right now, I think there's 3 or 4 states in the country which are experiencing outbreaks of avian influenza. Then we responded to CCHF, Zika, Nipah, the cases with preparedness for Ebola, and the occasional cases of Mpox that continue to trickle in now with the second PHEIC being declared for Mpox. Mass gatherings, I've already talked about. The Metropolitan Public Health Surveillance Units is an attempt. Dr. Meera mentioned about the initiative, the Health Infrastructure Mission, the PM Abhim, which is a major thrust to the health infrastructure in the country. And under that, we have been offered this opportunity to strengthen our urban surveillance. Urban surveillance, realizing during the COVID period that urban areas are the worst affected, both in terms of the impact of any outbreak and the services that exist there. So to strengthen that, these metropolitan public health surveillance centers are being established in 20 cities as a pilot, and from there, maybe we may expand them further. So while a lot has been achieved during these 20 years, we have followed our own growth curve. There have been stumbling blocks, there have been challenges, impediments but they've been addressed to the extent possible through the supportive supervision and guidance of authorities. But there are a few challenges which still plague us, like the human resources. Having dedicated human resource, a trained human resource at district surveillance unit is the very basic minimal that is required to have a good surveillance system in place. Somebody who's able to pick up that the early warning signals existed and somebody was there to look for it and to alert the system. So while electronic, this is possible, but then India being such a huge country that at least at the district level, a fully functional unit is the minimal required. The private sector engagement that we have always struggled with because reporting in a lot of major part of the population, now it's said almost 60%, 65% of the population seeks healthcare from the private sector. So if the data doesn't come, the surveillance data, the indicators, the early warning signals do not come from the private sector, then we are essentially basing our decisions on just 40% of the healthcare services that we are catering to. The e-health records, because it's an electronic system, e-health records would help immensely. So if this e-health records, uniform e-health recording system is available at all the health facilities and all the major hospitals, then there is something which humans generally do not want to do, and that is the data entry thing. Data entry is probably the most an unwanted job for a human being to do. So if we can have electronic health records available, then it could be automated as well. So efforts are on in that direction. Data exchange across platforms. So when platforms are created without giving a thought to their interconnectivity and interoperability, then there's a challenge. So if one sector creates its own system and then it doesn't talk to the human health surveillance system, then the need, then the logic of having an integrated surveillance gets defeated. And with recent times, the issue of data safety also happens to be one major issue. I said there's millions of records which are fed on a routine daily basis, almost about 100,000 records or more than that are fed into the system. So ensuring the privacy of this data, there may be personal identifiers which are available on that data record, and ensuring that this remains safe, secure, and it is as per the government policies and the legal framework. That's another major challenge that we are looking at. So I think that is the time that was available for me, and I haven't overshot that. So I'll stop here, and maybe a follow-up discussion and questions on this we can take from here. Thank you very much.
Thank you very much, Dr. Himanshu. That was incredible survey, incredible journey through the system, and what incredible sophistication we see. So much for Australia to learn from you. And I have to say, I have been as a visitor to the Public Health Emergency Operations Centre, and I agree, it's very impressive. I'll now hand over to you, Sarah, for some comments.
Thank you. And thank you, Dr. Himanshu. That was a fascinating presentation. And I think the thing for me is I'm just blown away by the complexity of it. I think in Australia we have a federated system and we have challenges with that. But you're talking about 36 states, 769 districts to be able to manage that data and coordinate and bring those different platforms together. I think that's an enormous achievement to be able to do that. So I think we've got a lot to learn from you in Australia with it. I think we've got a much simpler system when I hear what you've been able to achieve. I think the other really key thing is what I've really liked that I've heard about this system is that you've covered the whole surveillance system. So it goes right from the person at the ground, as you said, is one of the challenges, is the recognising the diseases and reporting the diseases. But it actually then takes in the data, the integrity of the data, how that's collected, and then right through to the rapid response teams and then the FEOCs and how that's actually responded to. So it's the whole gamut of the system, because a surveillance system, I think, is often looked at that people consider it's just a data system, but there is much, much more that goes into a surveillance system, and it's about that collation of data, the analysis, how it's used, how it informs public health policy. That's the critical components of it. And I can see in your timeline that you've done over that period of 20 years is how much that has developed over that period and how much you've been able to achieve by getting actually the electronic platform. And again, I was just marveling at how do you actually manage the data and the quality and the integrity of the data through that process with that many inputs coming in. And I think that's, a major achievement for you to be able to detect and pick up these different trends and being able to provide that feedback, which I think was a critical loop, that you are bringing that back to the states and to the districts as well, so they can see how they're performing, and also that there is that information loop, because often it's a one-way track. What I'm keen to hear, and I think you've really highlighted about the partnerships being a really important component about the development of the surveillance system. And, it started way back with the funding of the World Bank, and you've got your partnership with UNSW. And I'm keen to hear from you also then about those developing partnerships that help you move this surveillance system into the future, and what that, well, I guess I'm really interested in what the next steps will be, because as you may or may not be aware, as part of the interim Australian CDC, we're moving to be a standalone CDC, and data will be a critical enabler for one of the underlying principles for the Australian CDC. And as part of that process, we're looking at key components about developing a new national public health surveillance system. And in conjunction with that, looking at wastewater surveillance system as part of the establishment. And through us in the One Health unit, we're also looking at how we can actually improve One Health surveillance. So I'm interested to hear from you if some of these things like One Health surveillance and how you can actually partner up, and I heard that you did have really good strengths with the animal industry or with the partnerships with the animal areas. But some of the complexities we have is about the ability with the different platforms to connect, and that interoperability to be able to share data. There's a lot of privacy issues. There's a lot of sensitivities on the animal side about that, but how we can actually get better One Health data in that process. And there'll definitely be a bias from me because that is my interest, but I'm really keen to hear from you about what your future ambitions and how you potentially could bring in the One Health data.
Right. Thank you for those encouraging remarks and the views that you had about that surveillance system. Thanks for appreciating it. Yes, it has taken a lot of effort over the 20 years, and still it is far from being perfect. No system can be perfect at any time. So there's always the scope of further improvement. So what we are looking at, it's interesting you mentioned One Health, although that's an area that you excel and specialize in. But One Health is essentially a collaborative project, a collaborative, and the term that WHO has been using recently is collaborative surveillance. So we are also expanding in that direction to have a stronger collaborative surveillance system in place, which can get inputs and share data to the other surveillance system. Like Animal Husbandry Department, they are in the process of establishing their own animal husbandry, animal health surveillance system, a disease surveillance system. So once that electronic system comes in, and it's good that we are talking right at the initial stages when it is being set up. So there'll be a point in time when these two data systems, they talk to each other without any human intervention. So the early warning signals that we generate are passed on seamlessly to that sector, and they are alerted so that adequate response and measures can be taken, and vice versa. So that's one area, and it's not just about animal husbandry. It's about wildlife. It's about the interfaces where human-animal interface happens, where wildlife-human interface happens. So those are the areas that we are focusing on. Wastewater surveillance is essentially a new technique that has gained a lot of currency after the COVID pandemic. Various countries across the globe have used wastewater surveillance for various diseases, which has expanded beyond COVID. And India is also at National Center for Disease Control. We have a unit which is looking at wastewater surveillance, and it's more expanded scope of use. We also look forward moving ahead from detection to maybe, if I could say, prediction of outbreaks or epidemics. So there's a lot of data which is clean data, which is verifiable data, which is now available. And the use of this data for creation of models that can actually help predict outbreaks before they happen. So that's where we look forward to having partnerships with UNSW and other agencies which are working in this modeling, mathematical modeling, and predictive analysis domains. We further moving ahead, we would also like to see a further reduction in the efforts of data capturing and data entry. So tools which are based on technology, systems like facial recognition in the hospital OPDs, and then linking up them with applications on mobiles, which the doctor sitting over there can use. So minimizing the efforts of data entry to the extent possible, and having maximum inputs from these health facilities flowing into the system, which then enhances our surveillance quality and a timely response which can be initiated based on that. So these are some of the reflections on the comments that you just made.
Yeah, that's great. Thank you very much. You did comment about the ability to be able to access all the data, and that the private sector is an area that's untapped at the moment. Do you have potential plans or ability to be able to incorporate that into the future? Do you foresee that's possible?
So that's the beauty of any electronic system. I mean, it can be tweaked, it can be twisted, it can be made to talk to other systems as long as they have common attributes. So the government of India, having realized that, it came up with its National Digital Health Mission, wherein there are clear-cut directions to all the stakeholders, all the departments and ministries who collect data electronically to maintain certain standards. These are the prescribed standards which help mainly in interoperability and interconnectedness of the systems. So yes, there's ample scope that newer systems which would come up, which may come up, can be connected with this one.
And do I have time for just a couple more questions, Rebecca? Is that okay?
Yep.
Great. Thank you. A couple of other things that you mentioned, Dr. Himanshu. You mentioned about the community surveillance, that you did involve the community. Could you just outline a little bit more about what that program involves and how you get the data, clean data from that?
So, as I said, it was initiated last year, January 2024. Now we are 1 year into that. And the idea is that community participation for the academicians among us, we would recollect that primary healthcare approach is based on 4 pillars, one of which is community participation. So without community participation, this entire effort of detecting early warning signals, they are incomplete. So once the community becomes partner, you need to offer them a tool, a portal, or a modality through which they can report what's happening around them. While most of it may be noise, but the signal that emanates from that noise can be a very useful one. So because it's just been about 1 year, we have seen this tool getting popularized among the community. And once we get a lot of input on that particular tool, then we can have technologies such as maybe an AI-based solution assisting us in filtering out the background noise and picking up the true signals to act upon.
Yeah, sounds very exciting to be able to progress with that. Thank you. So probably my final question, because I'm mindful that we will be going out to the audience for further questions. What lessons or advice do you give to other countries that they can learn from your experience with the IDSP?
That's a good question. India has already offered integrated health information platform along with various other digital initiatives as digital public health goods. And countries have also, especially countries which are in the process of establishing such systems. They have expressed interest. So a lot of learnings that we have had during this journey, they have been shared with those countries in the form of bilaterals and multilateral platforms that Government of India is engaged into. So we have shared that some of the important reflections on this journey is that it's a continuous process. There's this technology which would keep on evolving, and there's deliverables which ultimately at the end of the day have to be met with. So that a balance has to be kept between the two. And while AI may offer lots of advantages as we move ahead, and everybody's talking about it, health sector probably with a great enthusiasm, but then ensuring that AI helps us in achieving our mandate, our objectives, and at the same time keeping the data safe and secure, and those aspects would also have to be kept in mind. Interoperability has to be the bottom line for any country or any stakeholder who's thinking of developing such a system, that it will have to talk with another system to be able to fully do justice.
Thank you. Well, I'll just go back to you, Rebecca. Thank you.
Thanks, Sarah. That's great. And look, I think, as you know, we have an interim Centres for Disease Control and setting up all of these systems as well ahead of us. So I think, great lessons learned. So we have some questions from the audience. I guess I have a question as well, which is possibly naive, but can you utilise your system for chronic diseases and injuries and other conditions for surveillance and registry, creating registries and things like that?
Yeah, so this system was mainly for, when I talked about integrated disease surveillance program, its mandate was communicable diseases and outbreaks. But that example, it has been successfully tested. It has established that it's a stable system, and it can also be used for non-communicable diseases and injuries as an incident reporting system. So while a lot of that data, especially related to injuries and road traffic accidents, that system exists, but it's in a very different vertical. It's not the Ministry of Health, which is the primary lead agency on that. It's the Ministry of Roadway Transport and Highways, and essentially law enforcement, which are the major stakeholders in collecting that data. So if that system is connected with the health system that we have, then it would happen. It would help both the stakeholders. The non-communicable diseases, they are also having a system where the screening results, the follow-up of the cases that's detected, and it's all an electronic database as such. So at some stage, probably we may think of having a system which goes beyond just outbreak detection and response, communicable disease surveillance to disease surveillance in total.
Right. We've got a few other questions. We do have, and again, we have got a very expert mathematical modelling team in the School of Population Health. So I'm sure there will be people on the seminar here very interested in what you've got to say. But I'd like to come to the community reporting and scanning of media reports. At the Kirby Institute, led by Professor Rana McIntyre, there is a program called EpiWatch, is AI tool to scanning open source data. And we do have a question about how you manage your open source data. So there's a lot of resources that might be needed when you're working with open source data to verify early signals and deal with false alarms. How do you manage that?
So the designing of the tool is essentially based on these considerations that yes, open source data has to be utilized. That's the one which is readily available. But then that was our concern also to start with, that there may be false alarms, and there were false alarms to start with. But as the tool has been taught, its model has been, as it gets more and more data fed into it, it learns to make a distinction between a signal and a noise. So that's what we have achieved. So I'll give you an example to start with. We were getting alerts on people in forests who have been trampled upon by an elephant, and that also happens to be an unnatural death. So it started indicating us that probably there's a need for outbreak investigation there. But that as we kept rejecting these incidents with reasons assigned for the rejection, the AI tool started learning that these are not the incidents that we are looking for. And now it's a very refined version of it. We don't get lots of false alarms generated from this.
Wonderful. And now we have a question about training. So did the same health staff who handled the weekly aggregate reporting also transition to the electronic case-based system? And if so, was NCDC responsible for their training?
So training has always been a major area. I mean, any transition, even an ongoing activity, is based on adequately training the people who are responsible for it. So this transition, when it happened from IDSP, it was planned in 2018. And from 2018 to 21, almost a 3-year period of intense training at all levels, from the district to the field, to the actual service providers, the community workers, healthcare providers. They were all offered various levels of training to make them familiar about this newer system. Training is not just about how to report. Training is about making use of that data, to be able to epidemiologically interpret that data, and to be able to respond as well. So that's where programs that we have, like the Sector Connect program, which is essentially a program based on the One Health approach, where participants from not just the health sector, but the allied sectors are also brought together as one group, and they are trained together so that they are able to pick up the early warning signals and take appropriate measures on that.
And we're almost out of time, but I've got one more question from, and again, because we're university people interested in research, and the question is about, are there plans for existing platforms for research using the data, or training partnerships with academic partners in India and internationally, so that, you might, better utilise that data that you're collecting?
So there's a lot of requests that we do keep getting from researchers who are pursuing their doctoral studies and others as well. So there's a protocol in place. It has to be recommended by the university concerned and is examined at the level of Director NCDC, and the formal permission is granted. We have shared data, IDSP data, with researchers time to time, made it available, because ultimately it flows back into the system and helps us make it better.
Thank you. Sarah, did you have any final questions?
I did have one, and then I didn't think we had time for it, but that's okay. Probably the key part was I was just keen to understand, with this data and all the changes and what you've had to support it, could you just tell us just about one or two public health policies that have actually changed or have evolved as a result of this program?
So, policy level changes as a result of, now that's for probably somebody who's at a higher pay grade than mine, not to be able to comment if they've seen it that way. But I'll certainly say that the data is being used by all stakeholders, right from the district level, the decision makers, as in the district surveillance officer, the district administrators, to up to the central level, maybe the health minister's office, who uses this data. And I also
may I come in there? May I come in there?
Also joining in.
You see, you were talking about policy changes. Policy changes, is a very broad term. Policy is something which could be used for a long term. Policy could be an immediate short-term change that occurs. Now, for example, there was an outbreak of GBS in Pune, which was captured and even investigated. So it led us to identify the source and take an immediate decision. That's also a policy decision. And you can have a long-term effect as well. For example, IHIP per se has made a lot of changes in our approaches to investigating cases. So to assess every decision to be affecting policy on an immediate basis is a very difficult question to answer.
Yeah, that's all right. I didn't mean to throw a difficult one to you at the end
it's
there.
not difficult. It's very simple. This tool is definitely going to help us make policy changes, but those policy changes are not going to be visible on an everyday basis. It will be visible on a long-term basis. So that's my take on your question. Rest I'll let Dr. Himanshu answer because I'm going for another meeting. Thank you so much. Yeah.
Thank you, Dr. Atul. And for our audience, I'd just like to comment that this was Dr. Atul Goel, who's the Director General of Health Services. And thank you very much for your participation. Yeah. Thank you. We are out of time now. I think we at the end of the seminar. So I'd like to say a huge thank you, Dr. Atul Goel, Dr. Mira Duria, Dr. Himanshu Chown, Dr. Sarah Britton. Thank you all for participating in this. It's been, it's an incredible journey, and the sophistication of the disease surveillance program in India and the learnings that we in Australia take from it are significant. So thank you very much for your time, and I look forward to seeing you again for our next webinar. Thank you very much.
Thank you very much.
Thank you. Thank you.